Hi, it's Mary Lou Novak with Resource4care.com. Resource for Care interviews healthcare and wellness professionals so that seniors and their adult children can learn about navigating healthcare when we get that just a little bit older. Sherrie's a little too young for this.
I am navigating with my
parents. Okay, with your
yes.
parents, right. But the reason why we have Sherrie here today is because she has a wealth of experience in nurse practitioner care as well as hospice and some psychiatric education, which I'm eager to hear about. Yeah. But today our topic is trying to explain the difference to you between hospice and palliative care. Sherrie is a nurse practitioner with Hope, Hospice, and Palliative Care. So who better to have explain the difference? So when you're working with clients, Sherrie, what do you find? You call them clients or
patients
or families? Okay.
Yes,
everybody's a little different.
Yes.
Yeah.
Yes.
So when you're working with families and your patients, what's the biggest misnomer or thing that you find yourself explaining over and over again? What would be something that jumps out?
I would say that hospice is a bad thing, and
that's what they think?
Yes, that we're giving up on their loved one, and that by coming on hospice, we're actually expediting the end of their life.
Okay. I would think it makes it very real for them. When,
it does.
Yeah.
It does. Especially, when you're in and out of the hospital.
Right.
And each time you come home, usually people do not get back to their baseline where they were before.
Yeah.
But the fact that they came home kind of gives the family hope that things could get better.
Yes.
And so when we come in, we have learned not to strip people of their hope, and that's why I love that we're called Hope, Hospice, and Palliative Care.
I didn't think of it that way.
Yeah, our goal is to infuse hope into the situation. Actually.
That's wonderful. Yeah, I've seen that often. I owned a home care business for 12 years, and we'd have clients go into the hospital. Let's say they, had pneumonia or maybe a fall or something like that, and they want the client or the patient to be safe, and they end up being in bed more and things. When you say they're at the same level,
right.
That's some of the issues, right?
It is, and I think because the family is right there, it's in their face. I think of it like a forest. The family is looking at this one tree, which is how much they love that patient. But as a clinician, if we step back and look at the entire forest, we can see that there is gradual decline, that sometimes it just takes someone to compassionately explain that yes, they came home, yes, they're able to talk, but at this point, based on Medicare guidelines, they would be appropriate for hospice.
Right. Do you want to explain the guidelines of, because it's not the patient that necessarily gets to choose, right?
Right.
There's things that are specific. And today, Sherrie was speaking at a live event having to do with primary care physicians. And there's a component to that too, right? When it comes to hospice?
Yes. So generally, hospice referrals, when they come in, it comes from the primary care provider. Sometimes we get them from the hospital, and sometimes they come from specialists.
Okay.
And we can have patients self-refer themselves.
They can. I didn't realize that. Okay.
They can call in and say, hey, this is what's going on.
Okay.
Could you come out and talk with us and explain hospice?
Right.
If they were physically appropriate, then we would reach out to their provider to ask for an order.
So you do need an order, though, in order to start. Well, what if somebody doesn't have a primary care physician?
That is a great question, because sometimes we come up against that.
Yeah.
And that is when we might reach out to one of the nurse practitioners in the community. There's about 3 or 4 of them that provide primary care.
Okay.
They can go out, see the patient, do a history and physical, document that yes, these are the things that are going on and they are indeed appropriate.
Okay.
And then they could refer the patient
to
us or to any hospital.
Okay. All right.
Yeah. Another it's few and far between, certainly the exception and not the rule. If a patient is closer to the end of their life, then I could go out and say, this is definitely going on. If I can track trends, if I can look through their records and see what their weight loss, falls, skin breakdown, infections, frequent hospitalizations, I can document that, let the patient know that they are appropriate for hospice, and then they could either come onto our service or they could reach out to any hospice. And use my documentation.
So you need a nurse practitioner or
a physician.
Exactly. Interesting.
Or a PA. Sometimes we forget about physician assistants, but they can write that order for hospice.
All right. So let's talk about what it means. Well, what do you want to talk about? You want to talk about the difference, or do you want to talk about what the qualifications are?
I think we can say a little bit of all of that.
Okay, great.
So Medicare has very clear guidelines that makes people appropriate for different diagnoses. So like for cancer, if you have cancer with metastases, so say it started in your colon, and now it's in your lung, or started in your breast and now it's in your brain or your lymph nodes, then, and you don't want treatment or treatment has failed, at that point for cancer you're appropriate for hospice. Heart disease, they state that you should be short of breath at rest, have difficulty with swelling, fatigue. Sometimes people get so short of breath that they can't even eat, so there's weight loss. And at that point, for congestive heart failure or end-stage cardiac disease, you would be appropriate. And of course, people will have had to talk with their specialists and try different medications. And they just haven't been
just to get results.
Right. Lung disease, same thing, shortness of breath, like COPD or emphysema. And then we have like liver cancer, liver failure. We look at lab values, but a lot of it, the actual organ has failed. We're looking at weight loss, infections, frequent hospitalization.
And that might show up differently based on the diagnosis they have.
Absolutely.
But you look at the same things.
Right. And needing more help with activities of daily living. Like maybe 2 months ago they were able to make themselves a sandwich, but now they can't get out of bed. Or 4 months ago they were able to eat a regular diet, but now they're getting choked on their foods. Those are things that we document to show that they do meet guidelines.
I was surprised at the information you shared this morning that dementia by itself now is no longer.
It's not. No.
Qualifies you to have hospice.
There were a few in years or so. Medicare has changed some of the guidelines and the diagnoses that we can use. Dementia is one. Failure to thrive used to be one. And I believe the reason they did that is because it's kind of a catch-all diagnosis.
It's like the miscellaneous category of diagnosis.
Exactly. And there's no definitive, like, we can quantify.
How do you measure it if you...
There's no way. And Alzheimer's is still kind of difficult like that, you know.
Because it's a progressive disease versus dementia may not be.
Exactly. There is still a bit of a catch-all, but we rarely use it. It's called severe protein calorie malnutrition. So for patients who have cachexia, which means even though they're eating, they just cannot gain weight and they're losing weight.
And not absorbing any nutrients from what they eat.
Exactly. Because families are like, I'm feeding them. We believe you. But at some point, our body just literally focuses on the most basic of tasks, you know, breathing, and so even absorption kind of falls to the wayside at some point. But as far as severe protein calorie malnutrition, we look at albumins, which it shows how much protein, how much absorption.
Is that in the blood?
It is. And so that's difficult if they've not been out to see anyone. We don't have that measure.
So you don't have any measurement of where they were versus where they are now.
And in those situations, I have had the nurse practitioners who come in and do home care, primary care, take them on and draw their labs, and then we can use that if they choose to come onto our service. But basically the goal of hospice is to find a box that someone can fit in so that we can say to Medicare, this patient is appropriate and they will be in the correct level of care. And that's often how I present it to patients. Instead of saying hospice is because you're dying, it is really about what level of care
Right.
you need.
Right.
So palliative care it's for people who are living and doing well, and the hope is for the nurse practitioner to come in once a month, communicate with the primary care provider or the specialist, and
Right.
really to advocate for the patient. Say the patient has swelling but low blood pressure. We kind of collaborate with that provider to figure out how to get both of those balanced.
Now, is it typical that somebody in palliative care, one of the things would be that they can't get to a physician? Is that why it's mainly in the home, or?
Well, so if we come in and provide palliative care, they do have to have a primary care provider. So since COVID, several primary care providers will do telehealth, but that's not as common as it used to be. And so oftentimes when we go in, the patient's like, oh great, you're coming in, I don't need a PCP, but they still do, because we are not the driver of their bus. That PCP or the specialist, whoever sent us in, is still who they would, speak
Yeah, you're there to envelop them in care and support on their journey, not necessarily be the driver.
Right, and I see us as being the eyes and ears of that provider in the home. And so if patients are just not doing well, we can go in and say, okay, this something that their provider may never see. This is what's going on, and so this is how we can help to get these symptoms under control.
Yeah, and I can see that, like you mentioned earlier, you've been on this journey, or your people have many, many times, and you see certain signs that mean something, and it's good to have that professional practice in being able to share that information with the parents, so they see the signs. They begin to understand what's happening.
Absolutely.
Yeah, that's really supportive.
It is. And the majority of patients that come onto palliative care, we see them for 3 or 4 months, try to get those kind of annoying primary symptoms that are bothering them under control.
Yeah,
and
the things that are keeping them from thriving.
Right. We step out. The goal of palliative is to get them back to a baseline. There are sometimes that a patient is hospice appropriate, and this is how I tell my patients, there's palliative and then there's hospice. There are patients who are hospice appropriate, but in order to be appropriate, it's not just physical. You have to kind of embrace the hospice mentality and be emotionally and spiritually, relationally ready for hospice. And so oftentimes we will get palliative referrals for patients who are hospice appropriate but just not ready. And when we go in, it's not like we're like, oh, we're going to go in and convince this patient. We just establish rapport, talk with them about symptoms. On every first palliative visit, we fill out that post form which says, if my heart stops, I do or don't want CPR. So we just start this active conversation that hopefully isn't frightening, because it's happening in their home. Palliative nurse practitioners in general are able to communicate in a way that doesn't frighten patients. It's just kind of like, this is what's going on, and explain. Oftentimes the knee-jerk reaction when you ask people, if your heart stops, do you want CPR? Usually they're like, yes, absolutely. But then once we talk about how if our heart stops, that means something critical is going on at this point in our life. Of course, there are other circumstances where people are in their 20s, or something happens that can be
a
overcome.
specific incident.
Right, and so we just try to find out a way to not just deliver difficult information, but to collaborate with the family, and communicate in a way that they can either choose, yes, I will go into hospice because I need that care. A nurse practitioner once a month, and my physician's visits once every 3 months is not cutting it. I need a nurse in here twice a week. And so those are the biggest difference if you're presenting it based on level of care.
And I think the other difference, when you said the person's ready, it means also that they're saying no to certain things, certain things that are prolonging treatments and things like that. describe like what would be an example of that?
So like with a patient with a cancer diagnosis,
Right.
If they are saying I'm ready to go on to hospice, then they are agreeing that they no longer are wanting aggressive treatment, chemotherapy, radiation.
Because sometimes the quality of life, I mean, for some people,
absolutely,
it does get
absolutely, and
a strain.
Just because we can do something doesn't necessarily mean we should. So we can pull things out, and it really comes down to what do you want these last days, weeks, months
journey
to look like.
Right.
And if a patient has chosen, I don't want to be going back and forth to chemo and exhausted for 3 days after and vomiting and my kids watching me suffer.
Right. And I'm in the hospital more than I'm home or whatever to recuperate.
So even with Alzheimer's, generally when patients come on with that diagnosis, we will stop Namenda and Aricept, the medications that generally treat that. And it's very similar to cancer. Those two medications, they're not necessarily curative, but the goal is to prolong or
slow down progression.
And by the time we use a FAST scale, which means like we look at incontinence, ability to speak, ability to eat and hold yourself. By the time they get to that point, that generally those two medications are not slowing things down any longer. And so we generally stop those. We generally stop medications like vitamins, things, lipid medication, because those are for people who are going to live at least 10 years longer. And so you do a part of embracing hospice is saying, okay, these medications aren't helping. They may not be hurting, but they're really not helping. So we're going to move them off the table so we can focus on the medication.
And people have to be ready, to say yes to that, emotionally, mentally. There's probably things that are added too, right? Pain management and those types of things.
And some patients, for whatever reason, they don't want morphine or Ativan in their homes. There's a plethora of reasons, but I always tell them, you may never need this, but if you do at 2 o'clock in the morning, we know it's there. And so we get that in and tuck it in the back of the fridge. There's generally liquid morphine, either liquid or tablet forms of Ativan, which helps with anxiety, something for fever, something for nausea, something for agitation and restlessness. And we just tuck that away, and when the nurse comes in, they explain all of the medication, but we may never use it, but more often than not, we need it.
Because you just want it to be a comfortable journey. So you had mentioned earlier that you were getting a certification, or you did, in psychiatric medicine. How do you find, what went into make your decision to do that, and how is it helping you do what you do?
So I've been a family nurse practitioner since 2010, but I have always gravitated toward hospice and psych, and so in 2015 I started working as a psychiatric family nurse practitioner.
Oh, wow.
Prescribing medications. That was my basic role. And I believe medication is very important. Often people will shy away from medication, but it really does help with those serotonin levels. But after a while, I thought if I could also provide therapy, that would be even more helpful. And so I just made the decision to go back to get my psychiatric certification so that I can provide therapy. And I would love, I haven't quite figured it out, how to combine the two and maybe do death doula or do therapy that helps people resolve some trauma or family issues, things that are holding them here. I'm just figuring that out. I just got my psych certification. So
that's wonderful. I don't normally share this, but I'm a life coach, so I help people discover what fear might be holding them back. And it is interesting when there's an awareness. There's a lot of self-healing that can happen without, not that medications are bad, but it's another tool. It's just another tool in the tool belt to try to just live a better life.
Awesome.
So so you just recently got your certification?
So Yes, I did classes, which I'm not great in school. I'm a procrastinator, but I struggled through, got finished class, and then I procrastinated about taking my test because I had heard it was very difficult, and it was very difficult. It was the hardest test I've ever taken.
Really?
Right. It was terrible, but I passed, and so now I'm
Right.
dual certified as
Okay.
a family nurse practitioner and a PMHNP, which is a psychiatric mental health.
Okay. So what are some of the other professionals that you work with when you're in the home?
Yes.
With, not you, but Hope is in the home
Right.
helping.
Right.
What are some of the other professionals that you see or you work with?
Yeah. So generally, a patient, once they come on hospice, our medical director will become their provider. That
Okay.
doesn't have to be the case, but I usually encourage that because if there's
It's
an
under
event-
one umbrella, right?
It is.
Yeah, yeah.
And also we have easy access to our medical director. If something happens at 3 a.m,
Yes.
it's difficult to reach a primary care
Sure.
in the community.
Yeah.
So we have our medical director who's heavily involved in the patient's care, a ton of office staff, making sure that everything runs smoothly.
Right.
We have nurses who start off at 2 times a week, just evaluating that patient and addressing symptoms. We have CNAs to help with personal care,
Okay.
a chaplain, a social worker, a bereavement counselor who follows that patient's family for over a year after that patient passes on.
Wow.
We have volunteers. And I think that's it. We do get like Meals on Wheels involved,
Sure.
and choices, and so we do
Right.
interact with them.
Mm-hmm.
Because some people think hospice is we're going to come in and sit with the patient,
Right.
but really the nurses are there for
Mhm.
checking vitals, making sure any symptoms that need to be addressed are
Right.
addressed. Sometimes people need more care,
Yes.
so that might be choices if they have Medicaid or a personal
Yeah.
home care.
Yeah, that was going to be my next question. If they have, if they've been working with, let's say, a caregiver, whether it be private or through an agency, which I always promote an agency,
Yes.
the risk is a lot less. And if
Yes.
somebody gets injured in your home, you're not responsible because they have insurance. But do they have to give up their caregiver they've been working with?
Absolutely.
Or
not.
okay.
So if they have choices, and I may need to be corrected, but I think our CNA cannot be in the home at the same time that their choices
Okay.
caregiver is there. But other than that, they don't have to give up any.
Yeah, because they're both government benefits, so you
Exactly,
probably
so they
can't
can't-
overlap. That makes sense.
Exactly.
That makes sense.
Yeah,
Whereas if
yeah.
you're privately, it wouldn't matter.
It wouldn't
Yeah,
matter, no.
yeah.
So one thing that people have been getting helpful is therapy, like physical therapy, occupational
Right.
therapy, speech.
Right.
When hospice starts, those things are considered aggressive. We're trying to cure
Yeah.
and get you back. So once hospice starts, we don't interact
Right.
with physical therapy.
Right.
If I go in a home and physical therapy's there, I'm concerned because
Yes.
there's been some miscommunication.
Yeah, that miscommunication and maybe asking somebody to do things that they're not
Yeah.
capable of doing if they've
Right.
already been designated for hospice.
Absolutely.
Yeah. I remember it's a weird example, but my uncle was in the hospital and he had a fall, so they had him in traction, but then they realized the fall came after a heart incident,
Oh.
right? So the heart doctor came in, was treating him, but no one ever took him out of traction.
Oh, Lord.
And you're like, why do we have a heart patient with their foot up in the air? Like that doesn't make sense. So there's certain things that
Right,
just
they
don't
just-
make
yeah,
sense. They
right,
don't go together.
right.
Yeah, and to have a professional in. Well, I love that you have the follow-up after
Yes.
with the family.
Yeah. So whenever we meet every morning to talk
Is it like a
about-
team
as
or?
a team?
Okay.
Yes. Whether it is in person or
Right.
we have a HIPAA compliant text message, and we are just able to catch up with everything
Yes.
that's happened overnight. And when we find out a patient has passed on, we all sign a card. It gets delivered, and then our bereavement person reaches out to them at certain times, especially at birthdays and holidays.
Right.
Up to, I think, 13 months after the
Okay.
patient has died. And that is actually a Medicare expectation. Medicare
I
has done
love
that very
that.
well.
I love that.
Yeah.
Normally you're pushing for wellness things.
Yes.
Either before or after,
Right.
and that's really great that they have that part of it.
And at Hope, our bereavement person is Mr. RC, and he's actually a pastor, and so he also is able to provide spiritual support during that time. And we have our chaplain, Mr. Bobby. He's amazing. He'll go out and sing with patients. I was with him the other day, and they just have sweet spirits. And our team is well-rounded. We have a sweet team.
Yeah. Well, this interview and this talk is going to be posted on the resource, the number4care.com website. When you go there, you'll see links to the Aging in Memphis podcast, which this is one of them. You'll also see visual recordings, like links to YouTube. And we have care professionals listed. Those are people that in the 12 years that I've been in Memphis caring for people, that I've come across and I trust. And what we say is if you have a question, call any one of us or reach out to any one of us, and if we don't have the answer, we certainly have professionals like Sherrie here that we can reach out to and we've built rapport with, and they'd be happy to answer your questions. So we're here as a resource for all your seniors and your adult children that are going through this healthcare journey. Is there anything else? We have about 3 more minutes. Is there anything else that you'd like that we didn't cover?
So with the psychiatric piece,
yes.
I just want to encourage everyone. I know it's difficult if you're having a tough time, anxiety, depression, guilt, just feeling like maybe I didn't do what I should have done with my life. I would just encourage you to take a very brave step and talk with someone about that, because feelings and thoughts like that are seeds that will grow fruit, and we don't want the fruit in our lives where we are just sitting and ruminating over all of the poor choices that we made.
I agree.
I would just encourage you to talk with someone, be open to maybe therapy. Some people think, oh, I'm in my 80s, I don't need therapy.
Right, no.
We can all use therapy or a life coach at any point to kind of help us get over a hump that we've not been able to get over ourselves.
Right.
And so I would say one of the biggest thoughts going into the new year is to really make the decision, something you've never, this one little area that you've never been able to overcome, talk with someone about it so that you can walk into more freedom in 2025.
Yeah, I like the way that you're describing it, where you're describing in dealing with the issue that you're going to have more abundance.
Yes.
The other thing, the darker side, I guess, is that if you do suppress it, if you don't deal with it, it doesn't evaporate.
It doesn't.
So it goes somewhere. Yeah. It's going to come out in how you view things, how you act in situations. I say the life goggles that you see life through, or in some extreme situation where you're under pressure, and then all of it just comes flowing out. Right. So be proactive in 25, right?
Yeah. And sometimes it comes out as physical ailments.
Yes, I've seen that too. Yeah. So next thing you know, your shoulders are hurting and your back's hurting. Yes. Digestive.
Oh my gosh.
So let's 25. All right, we're going to make 2025 a strong year of abundance.
Yes.
Thank you, Sherrie. Thank you so much.
Yes, my pleasure.